So welcome everybody to today's Systematic Reviews Group meeting. This will be the last meeting of this academic year, and today we have two presentations, each lasting about half an hour, including questions. And we have Dr. Christos Salis, who will be giving a presentation entitled Language-Specific Dual Task Effects After Stroke, a Systematic or Scoping Review, and Dr. Gavin Stewart, who will be presenting on Complex Network Meta-Analysis, the Future of Evidence Synthesis, or a Wolf in Sheep's Clothing. Do you have any preference, Christos and Gavin, who goes first?
No. Do you want to go first, Gavin?
Okay, yeah, I'm happy to go first. Yeah,
Brilliant.
I don't think I'll take a full half hour.
That's absolutely fine, Gavin. That's fine. I'll hand over to you. Thanks. Oh, sorry, Gavin, are you happy for people to ask you questions during your presentation, or would you prefer people to kind of wait until the end?
We're a small group, so let's do it tutorial style and just ask away as we're toddling through, I think.
Brilliant.
Yeah. I'll just try and
Gavin.
share my screen. Okie doke. Can everybody see that?
Yeah, I can see that.
Yeah. Brilliant. Okie doke. So what I'll do is I'll have a quick introduction to network meta-analysis, just to make sure that we're all at the same page in terms of what network meta-analysis is. A little bit of an overview of one of the outcomes from a recent systematic review that I've done looking at antidepressants for chronic pain. And then a little bit of a discussion about where we're going with evidence synthesis. There's this kind of current idea that we want to move away from having hundreds and hundreds of pairwise meta-analyses, and we want to move into these network meta-analyses that are getting increasingly big and complicated. But also post-COVID, people have kind of picked up on the fact that we quite often need our evidence on timelines that are not conducive to doing great big massive network meta-analyses every time anybody's got a question. And this whole kind of rapid review type approach has started to gain more adherence beyond the kind of methodological community. So we've got these three different kinds of ways of going about things. What do we feel about them? Where should we be going? I'd be interested in what you guys think about that. So that's kind of what I'm planning on doing. Is that okay for everyone?
Yeah, that sounds great.
Yeah.
That sounds
Cool.
great, Gavin.
Okay, so a quick kind of whistle-stop tour into network meta-analysis. Okay, basically it extends a standard pairwise meta-analysis to allow comparison of multiple interventions or exposures or prognostic factors or whatever it is that you're interested in analysing. Usually it's interventions, usually it's phase 3 randomised control trials, but it doesn't have to be. It's a kind of standard in health technology assessment appraisals pretty much all over the world. And there's a huge array of options now for implementing these things. When I first started doing this a long time ago, you had to get to grips with WinBugs and that was it. And you could just do very basic little networks in WinBugs and anything else was just not possible. Now there's a huge amount of software to do both Bayesian and frequentist network meta-analysis. And it's not just called network meta-analysis, sometimes it's called mixed treatment comparisons, sometimes it's called adjusted indirect comparisons, and sometimes people call it all sorts of weird, strange things as well. And all it really is a way of making direct and indirect comparisons together. So quite often you'll have a drug A, and you'll have an awful lot of comparisons of drug A compared to placebo. And you'll have a drug B, and you'll have an awful lot of comparisons of drug B compared to placebo. But of course, the decision that you're interested in as a patient or as a clinician isn't, is drug A better than placebo or is drug B better than placebo? What you're interested in is, should I take or prescribe drug A or drug B? So you're interested in that indirect comparison. And obviously, if you know something about the relationships between these three comparators here, then you can infer the other elements. So if in this little example here, superdrug A is, if it's got a huge effect compared to placebo, and superdrug B has got a tiny effect compared to placebo, then you can infer that the indirect evidence of A to B would suggest that A is superior. And the assumption that you're making when you do that is that everything else is the same. Yeah, so the baseline scores of people aren't different in when they're on drug A and when they're on drug B. It's not an older population. Everything is the same. And that's this thing that everybody kind of gets their knickers in a twist about and called the transitivity assumption. So let's talk a little bit. We'll come on to that in a sec. Yeah, the other thing is that a lot of the time people have less confidence in the indirect evidence than the direct evidence. So people like that direct evidence. Partly that's because they're not worrying about this extra heterogeneity, if you like, that might be confounding the relationships. But also, I think it's because it's simpler. Because if you chat, once you get into this kind of analysis and you start thinking about it and you chat to the methodologists who are engaged in this space, sometimes we can see how the indirect evidence might be better than the direct evidence. So, for example, it might be less biased. You're only going to have head-to-head comparisons of things that work in certain directions, potentially, in some circumstances. So you might have more evidence, it might be more precise, and it might be less biased. So it isn't necessarily true, but direct evidence is always best. But whenever you're looking at grade frameworks or trying to look at the difference between direct and indirect evidence, people always think of the direct evidence as kind of closer to the truth in some way. And just to go on to this transitivity thing a little bit more, what I find about this is people use all these terms. You talk about transitivity and incoherence, and it makes it all sound much more complicated than it really is. All it means is something other than treatment different between the comparators? That's all it means. Okay, and the incoherence, if you've got a difference between direct and indirect evidence, that might be explained by transitivity. Okay, and it's exactly the same as when you've got your normal pairwise meta-analysis sitting there. Okay, what you're worrying about is the population different in some way? And you know how we have these kind of pretty random assortment of baseline covariates that people just choose to measure when they do a trial. You can look at them and say, is this the same population that's getting superdrug A and getting superdrug B in my network? Is the intervention delivery the same? So you might be worrying about the kind of implementation science side of things. Perhaps intervention A is the sexy, trendy new one. So it's always given much better than intervention B. Similar problems with the comparators, outcome measures, risk of bias. All of these things are things that you look at when you do your normal pairwise meta-analysis. You have to look at them in the network meta-analysis as well. Everybody okay with that so far? Okay. This is just a little pinched illustrative example. Then it's looking at the number of smokers failing to quit 12 months, and you've got an antidepressant and this NRT patch, and you've got direct comparison and indirect comparisons. And you can see that most of the evidence here is compared to placebo. So there's the direct evidence, and they've got 3 trials looking at that directly, and that's straightforward enough. But then they've got all this other evidence here from the placebo-controlled studies. And then they've got extra evidence if you add on other interventions, and you end up with this whole great big network. And you get all these different loops, all these different ways of comparing the effectiveness of one to the other. And all you do when you do network meta-analysis is that you come up with a weighted average of all of those indirect loops and the direct evidence as well, and you stick it all together in a weighted estimate. And that's what That's what your estimate is from your network meta-analysis. Everybody okay with that? Okay. Let's quickly talk about antidepressants for pain. So my kind of experience of network meta-analysis until I did this review was, you know, I've been on the kind of MRC biostats courses to kind of do it, and I've reviewed a few, and I've handled a couple of editors as an editor and so on. But I've not really had a great deal to do with implementing a modern network meta-analysis myself until I got involved in this research. Please don't share this, by the way, because this still isn't, this is just going through the publication process at the moment. So this was to look at the effectiveness of antidepressants for adults with chronic pain. So the population was very tightly defined, and everybody went off and did the standard kind of systematic review. And then we did our fancy network meta-analysis, and we did a fancy one with all the bells and whistles. And I'll just kind of show you the kind of results that were generated for one of the outcomes, just to illustrate it. So we've got reasonable complexity in terms of number of interventions, and it's not a particularly well-connected network. There's a lot of things that are compared to placebo, but you can see that most of the links between other studies or other arms are represented by single trials. And it's really only the duloxetine data where you're getting multiple studies comparing multiple different doses of duloxetine and placebo. So that's where you're getting kind of robust triangles. Everywhere else, yes, there are connections and triangles, but it's all relying on a single study or a couple of studies. We never like it when we're relying on one or two studies in evidence synthesis, because we know what our studies are like. Now, if you do your fancy all singing, all dancing network meta-analysis, one really nice thing that you get is you get a plot of the residual deviance associated with the individual studies. And this is telling you whether or not this study fits the model. So if you find that you're getting very high residual deviances for lots of studies, then it's telling you that you can't really fit a decent model to this data. And that's a really, really nice little thing that network meta-analysis gives you, that you don't always pull out of a standard meta-analysis. And you get your forest plot as per normal. So here are our log odds ratios for our different treatments and treatment dose combinations. And you get this ranking of the treatments, which is something that you don't normally see from either a frequentist network meta-analysis or your pairwise analysis, where you can say what's the probability that a treatment is top ranked, what's the probability that it's second ranked, and so on. And this is a really nice way of balancing how big an effect is with how precise an effect is as well. Yeah, so that's the nice little links nicely to decision models and to the actual question that clinicians are interested in answering. This is a dev plot, which is a way of trying to look at whether or not there's inconsistency between the direct and the indirect evidence. So it's one of the kind of newer models for looking at inconsistency. And when everything lines up now, these individual points represent studies, and you can see the kind of huge uncertainty on them. But the important thing is that they're all lining up on this line where the two models are agreeing with what that estimate is. So that's suggesting that there isn't any inconsistency. And you can look at the direct and the indirect evidence wherever you've got one of those triangles. So for all the comparisons where you've got a triangle, you can say, what does the direct evidence tell us? And what does the indirect evidence in that triangle tell us? And again, you can see that the direct and the indirect evidence most of the time are kind of aligning for this specific outcome. That's not universal, by the way. So it's just to demonstrate the kind of outputs that you can generate doing this. So that's all well and good. The problem is the cascade of complexity that we get when we use this method. So in this review, I've got 7 outcomes. Some of them are related. So, you know, some of them it's like I've got pain intensity, which is pain measured as a standardized mean difference on a continuous scale. And I've got substantial pain relief, which is do 50%, do how many patients experience 50% pain relief or better, which is an odds ratio. So it's 2 different outcomes, if you like, but it's really the same outcome, pain, just measured in 2 different ways. And then there's moderate pain, which is similar. It's just a different threshold. It's 30% rather than 50%. So some of these outcomes are related, but I've got 7 outcomes. Some of them are arm-based, which is when I'm doing the log odds ratios. Some of them are contrast-based, which is the standardized mean differences. For the standardized mean differences, I've got data that's post-intervention. And I've also got change data that you can just get the data from change scores, and you can't get the post-intervention. So I have to do 2 analyses for them. So before I kind of start doing anything, I've got 14 major network meta-analyses to run. I've then got to decide whether or not the best model is a treatment model or a treatment dose model. I've got to decide whether or not I can lump conditions. In this example, there's generally 3 conditions: musculoskeletal, fibromyalgia, and neuropathic. So can I lump them, or do I have to run separate models? I've got the different classes of the antidepressants that people are interested in. So I sometimes have to lump them. And then I've got risk of bias, which everybody's always interested in as well. And then I've got these fancy models for looking at the inconsistency, the unrelated mean effects models and the node splitting models. And I might want to explore residual deviance by chucking studies out that have got high residual deviance. Because this is a Cochrane review, I'm having to use a bit of software called Cinema. That means I have to replicate my network meta-analysis, but not quite as, but in not such a sophisticated manner. So I can't have separate arms where the only difference between arms is dose. So other than that, I'm rerunning my network meta-analysis. I'm also doing a whole load of pairwise analysis. So if you think about this cascade of complexity, some of these analyses are pre-specified, obviously, in our protocol. Some of them aren't. I can't predict whether or not I think I'm going to have a problem with residual deviance. And so, well, I've got 4 studies with high residual deviance, right? I want to rerun this, taking them out and see what difference it makes. So some are pre-specified, some are not pre-specified. Some are useful analyses, like I'd argue that one I've just described is useful. Some are not useful, like I don't think it's particularly useful to divide things by class when you've got very low sample sizes and completely different networks, because you can't really tell what's going on or why. But it's pre-specified in a protocol, so I have to do it even when it's pretty much useless or misleading. So you have this massive cascade of complexity. So we tried to handle that pragmatically. Yeah, so we use model diagnostics to choose between the competing models. We'll make judgments about exploring class, condition, risk of bias. You can't present everything. So if you use this kind of pragmatic approach with a protocol, then you're generating hundreds of models and you're presenting results from tens of models. If you were to try and kind of automate this in some way and do absolutely everything compared to everything else wherever it was possible, you'd have literally thousands of models. So watch this space for the antidepressant story, but for the purposes of this talk, where does this leave us in terms of synthesis? That's the question that I'm asking. And so really what I'm doing here is I'm reflecting on having done a big complicated network meta-analysis. How effective do I think it is? And so I think about my results, and I've got moderate strength of evidence, moderate certainty about some of my results, and low strength of evidence about others. And so if you said to me, you know, Gab, you can have a massive research budget, you can do whatever the hell you like, what would I do to reduce the uncertainty that I've got? I might do more network meta-analysis at finer and finer scales. I probably would add observational data to improve network connectivity, but that would come at the cost of having the problems of having different data of different designs, and some of the data being at very high risk of bias and all the rest of it. People would say and would encourage me to add the individual patient data to explore heterogeneity, and there are now fancy models where you can have aggregate and IPD data and RCT and observational data all in a network. And that's what I mean when I say, is that the future of evidence synthesis? Because it sounds very beguiling and you think, yeah, well, of course it is. But I'm not, having done it this far, I'm not sure that that is the future, okay? Because the fundamental problems remain, that you've got these poor studies, you've got subjectivity in the outcomes when you're dealing with pain studies. You need the primary research to augment the synthesis. So I think if you actually did some kind of formal value of information analysis on these three options, it would probably be very low. You'd end up saying, actually, my decision is robust. We don't really need to do any more than we've already done. And so then the question becomes, did we need to do this fancy network meta-analysis at all? And if you go to the Cochrane reviews, you know, if you look at all of the pain Cochrane reviews, all the pairwise ones, you know, all these drugs that we've included in this network meta-analysis, you'll find reviews of them. Some of them will be split up by the different kinds of pain, but most of these trials are in there. Most of the studies that we've got are in there. It's just the evidence base is just organized in a different way. So, as we said earlier, you've got this problem that if you've not got the NMA, you're not directly addressing the question. You know, you can go to that library, you can say, right, I've got headaches. What drug should I take for a headache? You can go for that, and it will show you the effect of all the drugs compared to placebo. It won't tell you what should I do, what's the best drug to take given that I've got a headache. So that's a problem. There's a very real problem of generating type 1 errors. Okay, so this is you know, the left-handed men wearing green socks type problem. You're analysing everything, absolutely everything. So you're analysing all the subgroups for all the drugs, looking at everything. You're going to find some pattern if you look hard enough. So then you start concluding that things are effective when they're probably not effective. So that's a critique, that's a problem with this. But note that we've got an awful lot of analyses in that cascade of network meta-analysis. So there's a problem with that as well. And the plus side of this hundreds of pairwise thing is that done well, it does allow real scrutiny of the studies and integration of clinical judgment with the exploration of heterogeneity. So if you've got some really good clinicians who really know their field, you've got really good trialists who really know the trials, you've got a depth of understanding of the individual trials if you do adopt this approach that you don't have if you adopt the network meta-analysis approach. The only time I go near the trials when I'm looking at that network meta-analysis approach is when the residual deviant starts shouting at me and I say, there's something wrong with that study. Okay. And then rapid review. Well, rapid review is almost a meaningless term, isn't it, at the moment, because it's a multitude of methods and it covers a multitude of sins. But in this specific example, you might think about doing a network meta-analysis just of the direct head-to-head studies. So you don't include all that placebo controlled stuff. That's exactly what NICE did when they wrote the antidepressant guidelines that we've got at the moment. Now, I'm a big proponent of informing decisions with rapid review. I think it makes a lot of sense to kind of try and make judicious shortcuts to make things cost effective and efficient. But you need to be really careful when you do it. Okay, so some people use the term rapid review and it's just an excuse. They're doing a bad review and they're calling it a rapid review. And the problem is it needs to be linked to decisions about the value of updating the information. So where rapid reviews inform guidelines, it can be really hard to get the guidance changed subsequently, because everybody says we've already got the guidelines, we've already got a synthesis, this has already been looked at. And it can be really hard to say, well, hang on, you only looked at the direct head-to-heads. Most of the evidence is placebo controlled. Even, you know, you might find that the direct and the indirect is consistent, but that could still change your estimates of effectiveness. That could still change your ranking of which drugs you think we should be prescribing. And this example that's just kind of come into press at the moment is showing exactly that. So rapid reviews, great, but come with a big health warning. So this is really where I can stop and we can have our discussion. And I'm really interested in what you guys think here. But my tentative conclusions are that complex NMA is useful, but it needs stopping rules, and that we need to kind of change how we think of how we're thinking about using it. We shouldn't be trying to use it to squeeze the last drop of information out of the data that we've got to inform the decision. We should be trying to use it more to look at course treatment effects and then saying, stop, this is dodgy data. So it really isn't a universal panacea that some appear to believe it is, in my opinion. Problem with the large numbers of the pairwise reviews is, apart from them not addressing the decision problem, is this left-handed men wearing green socks, and that is a massive, massive problem. But they do let you look at the data really, really well. And the rapid review, broadly defined, is often a really sensible approach, but it's often wrong. And I think you have to bear that in mind if you use it. So in terms of where do we go with evidence synthesis, it kind of leaves a big question mark hanging for me, because I really did think there was a kind of linking the big complex network meta-analysis that had everything in it to the decision model was a kind of universal answer. And it was just a case of resourcing things so that we could do that all the time. Having gone through that process, I'm much less convinced about it now. I'm really not sure what a kind of really good system would be for doing synthesis well, other than to say, you know, you really need to think about what you're doing and why you're doing it and how you're doing it all the time. So over to you guys for comments.
Can I ask a question, Gavin?
Go for it, Christmas. Yeah.
Actually, two questions. One is whether one can do network meta-analysis with behavioral treatments, because it was interesting. I presume they can. It's possible, because it was interesting to see to note some of your subjective, if you like, measures.
Yeah, it's not. I mean, I think there's been a big one done on CBT is quite often done in network meta-analyses.
Yeah.
Yeah, and if you can use it for anything. Yeah, as long as you've got decent trials and you've got the different arms. Doesn't even need to be randomized control trials, and you can do it with observational studies, any outcome or anything. Needs to be quantitative in some way, some shape or form. You need some kind of an effect estimate and some kind of precision or uncertainty. Beyond that, you can do it for anything. Yeah.
Okay, thanks. And the second question is actually more generic, and it's really, you alluded to possibly the inadequacies of big data science, and you know, I was actually I'm interested in that because big data is really quite fashionable in my field, and actually also impossible at the same time. And what I see people doing, they do quite a lot of relatively big data analysis with new stats, but also they also use new stats in order to with actually small data sets. And it's really problematic.
Yeah, you'll find a lot of statistical support for saying, you know, be really, really wary about how you use AI. Doug Altman very famously said he didn't want big data, he wanted small data, but he wanted it to be the right data.
Yeah.
Collected the right way. They often don't look very well at causation.
Yeah.
And so everything is horrendously confounded. They don't do that kind of deep dive into the studies and the meaning of the studies the way you would if you were doing a qualitative synthesis or if you're doing a traditional meta-analysis. And they don't kind of do the testing to destruction that a good statistician does, where it's like, it isn't in the protocol to chuck the studies out if the residual deviance is high, but I'm doing all these additional analyses. I'm basically trying to break it. I'm going, this is my result, can I break it? How hard do I need to push before I break it? I had to push quite hard. Okay, it's probably all right. Actually, it falls over really easy. You don't even need to try when you're looking at, say, adverse event data. It just falls to pieces for you. So it's that kind of philosophy of approach that a statistician takes to analysis compared to the AI lot. They quite obviously, it's just broad generalizations, but a lot of them just come along, chuck a couple of algorithms at it and say, look at our pretty patterns. So yeah, you're right to be really wary of that. Yeah.
Okay, thanks.
Sonia, you've got your hand up.
I do. Hi, Gavin. Very interesting presentation. Thank you. I was just wondering whether you have any idea of what sort of decisions are being made at the back of a network meta-analysis evidence. So is it more to inform or guide a clinical decision? Is it more technology assessment? Do actually people use this to then guide future clinical trial development? Is it, do you know?
Yeah, so it's massive for kind of clinical pharma.
Right.
And most mainstream guidelines in most countries are starting to be kind of derived or developed. There'll very often be a network meta-analysis. Whenever you've got a drug company involved these days, there'll be a network meta-analysis. It probably needs redoing, but there'll be a network meta-analysis. For other things, it's growing in psych, as we were just talking about. It's growing in the kind of behavioural interventions. It's growing in social sciences. Campbell are really interested in using them and doing them. Very rare still in the environmental field. So the range of applications is growing and developing. I've not seen them widely used in prognostic, diagnostic, any of that kind of stuff, but there's no reason why they couldn't be. It's just I've not seen them and I'm not aware of that.
Perhaps they are less pairwise in those fields.
You need a decent network to make use of it. And if you've
Exactly.
not got a decent network, then what's the point?
Yeah. Okay, thank you very much. I think I've lost Louise. She internet.
She emailed. She had connection problems, so yeah.
Okay, so I don't know whether she's going to try to rejoin, but I think
yeah, she just emailed me, just asking if I can to take over and facilitate the session. Yeah, so I'm more than happy to do that. So if there are no more questions for Gavin, we can go to Christos' presentation.
Okay.
Yeah.
Okay, thank you. I'm just going to share screen just to tell you a bit about my background. Can you see the slides? Yeah. So first of all, about myself, I'm a speech and language therapist by background, and I'm based in speech and language sciences, which is in Haas. I've done 3+1 systematic reviews. The +1 has just been submitted with a PhD student of mine, and this one is actually an additional one, which I'm doing with Rowan Gerard, who is a pharmacist, and she's actually in the audience, and Laura Murray, who I've collaborated with as a speech therapist. She's a speech therapist in Canada, my interest, our interest in this, where am I? Yeah. in this review is on the problems people have after a stroke with regard to attention as measured or as portrayed by a dual task paradigm. And we're actually at the point of writing up the paper. We've done all the data and we're just sort of looking at them rather now, and we're actually dithering as to whether we can call this a systematic review or a scoping review. And I was actually quite pleased to hear that Gavin had the same dilemma about the rapid reviews and so on. And it's actually a real problem when you look at the literature as to what you call, you know, a piece of evidence synthesis in general. But I'll give you a little bit of the background of the study. And essentially, a dual task paradigm is a neuropsychological paradigm where you observe behavior under two conditions. The first condition is when people are carrying out a task on its own, and another condition when they're doing two things together, and it's actually used in stroke rehabilitation and particularly physiotherapy studies. One particular asset of the dual task paradigms, particularly in comparison to standard neuropsychological testing, which tends to be pen and paper, is that they have, or they're thought to have, high ecological validity because they give you a glimpse of what the person's functioning might be like in real life situations beyond clinic. As I said, the dual task paradigm generates quite high attentional demands, and attention as a problem is quite dominant in people after stroke, both in the acute as well as chronic stage. And attention as a cognitive ability interacts with other cognitive abilities, notably memory and language. And a little bit about the broad neuropsychology is that attention as a capacity is mainly associated with right hemisphere functioning, whereas language is actually associated mainly with left hemisphere functioning. So the reason we undertook this review is because quite a lot of systematic reviews that focus on dual task studies, either in stroke from an observational treatment point of view, they came from physical aspects of stroke, particularly walking balance and upper limb strength and so on. There's been 2 systematic reviews recently on cognitive aspects, but no systematic review on language production in particular. And also there's been no systematic review that covers all stroke severities, particularly those strokes of mild severities such as TIAs, which have been sort of gaining quite a bit of momentum in the literature because it's actually an under-researched population worldwide, because these people have been assumed up until now to have resolution of their cognitive problems within 24 hours, but that is not the case. So the broad purposes or aims of the systematic review here is to identify and describe dual task language production studies in people affected by stroke and stroke aphasia in particular, and I'll say a little bit about aphasia shortly, to examine the range and types of dual tasks and linguistic measures that have been used in this literature domain, to discuss the diagnostic and therapeutic implications of the findings, and to identify gaps in the current knowledge base and highlight areas for future research. I mention aphasia here because as a speech and language therapist, my expertise is on people who present with aphasia. And aphasia, for those of you who don't know, is a cognitive problem which is actually specific to language, and it's particularly evident after a left hemisphere stroke. Given that when we do sort of cognitive tasks that use language, we also use attention, and even when we do memory tasks, we also use language. The language element in testing and assessment is actually quite dominant, even if it's not actually marketed or advertised or labeled as a language task. Moving on to the method, these are actually the search terms that we used. You know, it was actually kind of a standard Boolean, that's the word I was looking for, combination, and these terms were actually used in the title and abstract domains of the paper, because we really wanted to not to be overwhelmed with useless and irrelevant papers, because we've learned that from our previous systematic reviews. We looked into 5 databases and also some reference lists. There were 2 searches, and the most recent one was conducted in February, and we got to the point now of writing the paper and actually putting things together. Now, in terms of the inclusion criteria, we're interested in adults after stroke of any severity, observation as well as treatment studies that had speech or language production data. And also the other important factor is that the dual task language had to be baselined in the single task as well as the dual task, in the single task and the dual task. And just to give you an example here, is that most of the studies that, particularly from the physiotherapy domain, have as a dual task paradigm walking and talking. Okay, now walking and talking obviously is a dual task condition. Okay, but unless you have a comparator of language as a single task, you cannot actually make a claim that walking and talking have an effect on language per se. And typically these studies, which, and there's quite a lot of them, the baseline is actually walking, the single task, and the dual task is actually walking and talking. So here we're actually interested in studies that have a language task as a single task, as well as a dual task language study, which could be either walking or could be sort of listening under distraction, and so on and so forth. Yeah, and this is really the thing that that we came up against actually all the time in terms of rejection. There were 2 reviewers per record. This was actually independent at all stages. And when we had sort of some kind of disagreement that we couldn't resolve, we had Laura as the adjudicator in cases of uncertainty. And in terms of the data extraction, we extracted data not on forms but directly on tables. And again, that's actually something that we've learned from previous reviews, because we used to have data extraction forms, in one review a Word document, another review a Excel spreadsheet, but you know, it facilitates then data transfer actually. These are the variables we extracted from the studies in the the first 2 tables. Then it was dual task description and more about the speech and language aspects, reliability and fidelity information, and also the results. So a couple of results, and this is actually still still pulling the data together. There's been about 1,100 studies, and I haven't actually added the hand searches here. The records that we included were actually 18 studies, and these are actually some quantitative results from the studies, 49 and 88, 488 participants. The mean number of participants per study was actually 52. and the range was from 10 to 91 participants. Stroke severity was reported in 2 of the 18 studies. And, you know, this is actually the last slide of the results. We categorized, I've categorized the linguistic level, whether the study actually focused on words, sentences, and discourse, and the majority of the studies, 10 out of the 18, focused on single words, 7 focused on sentences, and 1 focused on macrolinguistic aspect of discourse. And so this is kind of where we got to. And the question I'm interested in asking is actually whether you think this actually can be, you know, labeled a scope as a scoping or a systematic review. And I just don't know. Yeah, thank you.
I think, in my opinion, it's probably systematic if you looked for studies in a systematic way. You know, if you search through various databases and if you try to collect the data, all the evidence that is available, I imagine it is a systematic review. But I would be also interested to hear what other people think. And I think also other features of systematic review might include, so as you already extracted the data, but there is also like risk of bias assessment. So I think it also depends whether you assess the quality of the studies.
Yeah. Thank you for that question, actually, about the quality of studies. I'll answer that first. The journal where this is actually going is Neuropsychology Review, and it's a journal that publishes reviews. Surprise, surprise, but it's explicit that they don't like rating scales. And okay. In the previous systematic research we've done, 3 actually, we did assess risk of bias, and it was, you know, it was actually it wasn't inferential, it was descriptive. And it wasn't particularly helpful because most of the studies were actually getting a poor rating.
Yeah.
And this is actually what's going to be happening here as well.
Right.
And you know, I think the most important aspect of risk of bias was actually the fidelity data we were interested.
Right.
Yeah.
But I think it's also then might be quite important to point out that you imagine that these studies have quite low quality, because it might, you know, affect how perhaps accurate these findings are. But I see that there are already 2 hands up. So I think Gavin was the first one who raised his hand. So over to you, Gavin.
Okay, thanks, Agbil.
No worries.
Yeah, I would agree with what the previous speakers have said there, that in order to define it as a systematic review, you need some form of critical appraisal, and as far as the journal and its scope is concerned, you can do risk of bias assessment without using rating scales. In fact, you know, most serious methodologists moved away from rating scales about 20 years ago. So, you know, a standard Cochrane risk of bias assessment,
yeah,
or a Campbell risk of bias assessment, or any half-principled risk of bias assessment would not have a rating scale. Okay. And yeah, I would look at Prisma and make sure that you've got your reporting right. And although it really upsets people when you use Prisma as methodological guidance, not reporting guidance, but if you can report everything that Prisma's asking, then you're probably okay in terms of calling it a systematic review. Now you've searched your multiple databases, you've done your screening really thoroughly with multiple independent reviewers. That's all fine. You've got clear inclusion criteria. If you've got a critical appraisal, you can probably call it a systematic review. It would be better if it was pre-registered, but if it isn't, then it doesn't matter.
That was meant to happen, but never did, because we started during COVID, there was so much that needed to be done, and it didn't happen. Yeah.
Yeah, and that's then the only other element that it needs to have is it needs to have a synthesis. But again, that can be a realist synthesis or qualitative or whatever.
It's going to be, yes. And this is actually, some of the results are actually going to feed into the qualitative synthesis, because that's actually what we did previously. But thank you for the point about the critical appraisal, actually. Yeah.
I think in addition to that, I think there is a ROBIS-I tool which you can use for non-randomized studies, and I think you have included studies that are not randomized control trials. So I think it might be worth looking at that one, because it's quite a good tool.
Which tool is that, Bill? Sorry, I didn't get that.
I think it's called ROBIS-I. I think Gavin might know it better, as he worked with some of the Cochrane reviews.
Okay.
Is it ROBIS-I?
Yeah. Does Campbell are working on another version of it as well. My advice on critical appraisal tools would just be to get one that fits your study design, and get the simplest one that fits your study design. Because what you really want to do with it is you want to say, I'm really worried about the fidelity in these studies, because that's the thing that you're concerned about. So you just want a critical appraisal tool that lets you say that as transparently and quickly as possible.
Okay. Yeah.
But the trouble with ROBIS-I is it can take like half a day to do one study, and all it says is this study is crap. So
yeah,
that's a good point. Sonia? Sonia, have you got a question? Yeah.
Yes, I do. Sorry, I lost you in my tabs. Well, actually, I was going to respond about whether this is a scoping review or a systematic review. And I think, in my view, for what you have presented there, it looks more of a systematic review. But again, that needs that component of having an element of a critical assessment of the included studies. And don't be afraid of concluding the studies are not of good quality, because that's a finding in itself. And I know it's disappointing, but it's part of the learning of the process, and also a valid conclusion to be publishable, as well as pushing the research area further into perhaps encouraging more robust research in that field. So I think it's a valid conclusion. I think I wouldn't pick an overly complicated tool for the critical appraisal, because the more complicated, the more the tendency is to assess that the studies don't have sufficient quality. But again, I think I agree with Gavin. I think the ranking or the scoring it's been gone for a while now. So it won't be difficult to find. I've put on
yeah,
chat.
thank you for that. I see that, actually, and I'll look into it.
I've never used that tool myself, but I'm trying to think where there is a repository of tools, quality appraisal tools. I can't think. Maybe Prisma would have some.
Yeah, in the past, we've actually adapted Cosmin for our purposes, which is a Dutch one. And also MMAT for another review. I think we did Cosmin on 2 of the previous reviews, actually, but everything was coming out as poor. It's not that's not the point. Actually, of course, it's poor, but it was mainly because the journal actually is trying to steer authors away from this kind of quantitative appraisal tools, actually.
Yeah.
Okay, thank you both. Thank you, everyone. Yeah. Okay.
Thank
Great.
you.
Does anyone else have any comments, perhaps? If not, I think it's almost 1:30. So these were 2 brilliant presentations. Thank you very much, Gavin and Christos, and thank you everyone for attending, and have a nice evening. Bye.
Thank you. Bye, everyone. Bye. Bye.